Castro. I'm the first speaker for FUO in children. First of all, I'd like to thank the organizing committee for inviting me to talk on this particular topic. I feel like I'm part of the tour group, and we're about to be we're about to be brought to the department store, and we're just given like 30 minutes to shop, and then it will close by 30 minutes. So that's how I feel. I was given just 30 minutes to discuss the infectious causes of FUO in children. The outline of the talk will be on the definition of FUO, the causes, the diagnostic approach to FUO in terms of clinical evaluation, laboratory testing, and the summary. FUO was first defined by Petersdorf and Beeson as fever of more than 38.3 degrees centigrade on several occasions, lasting for at least 3 weeks, with a diagnosis uncertain after 1 week of study in the hospital. Why fever of more than 38.3 on several occasions? This will eliminate the entity of habitual hyperthermia. This definition of FUO was first described for adults, and the habitual hyperthermia is for young women who presents with an undefined cause for fever lasting for more than a year. Why more than 3 weeks? Because this tends to eliminate self-limited infectious diseases, and diagnosis after a week of study in the hospital will give you ample time to complete the laboratory studies like bacteriologic and serologic tests, radiographic examinations, and skin tests. In children, definitions of FUO vary. This series will show you that initially this was started by Brevis, and he defined it as a temperature of 38.3 degrees or higher for 5 to 7 consecutive days without localizing signs and symptoms. 7 years after, it was defined again as fever of at least 3 weeks duration on an outpatient basis or 1 week in the hospital. And then fever for 2 weeks with no distinction made between outpatient or in-hospital status. And then fever for 2 weeks with negative preliminary investigations. The latest definition came from the Nelson's textbook of pediatrics, defining it as more than 38 degrees centigrade for more than 3 weeks in the outpatient clinic or more than 1 week in the hospital. For Figan and Cherry's pediatric infectious diseases, it has been defined as fever of more than 38.3 degrees centigrade for 8 or more days in a child for whom a careful and thorough history, PE, and preliminary laboratory data failed to reveal a probable cause. The 3 most common causes of FUO in children are infectious, connective tissue, and neoplasms. But in 10 to 20% of the time, a definitive diagnosis is never established. In a systematic review by Cho, involving 18 studies from 1950 to 2010, this involved 8 studies in 3 developed countries, namely USA, Germany, and Spain, and 10 studies in 8 developing countries. These were for children aged 0 to 18 years, and they numbered about 1,000 plus. The diagnostic criteria was for fever ranging from 1 week to 3 weeks. And at the time of publication, the diagnoses were as follows. Majority, or more than 50% of them, were infectious in nature. However, there were no diagnoses in 23% of the time. The good news about this no diagnosis is that it resolved in the absence of diagnosis in 49% of the time, 6.5% had persisting fever, and the outcome was not reported in 44%. Of the infectious causes, majority of them are bacterial in nature. And it all depends on whether you are talking about developing countries or developed countries. Because for developed countries, the more common bacterial causes are osteomyelitis, tuberculosis, and bartonellosis. For developing countries, it's more of brucellosis, tuberculosis, and typhoid fever. And UTI were found in both developing and developed countries. For viral etiologic agents, it's more of the EBV, which was found more in developed countries. For infectious syndromes, 25% of them were due to pneumonia, about 10% parasitic, which was more because of leishmaniasis, and fungal in 1.5% of the time. For non-infectious causes, it's about 11%, followed by your collagen vascular disease at 9%, and malignancy at 6%. Now let's look at the local data. I found 4, and these were from 1977 to around 2005. And in these cases, majority of them were because of infectious causes, followed by malignancy, and then collagen vascular disease. Unlike the international studies where it's infectious, and then collagen, and then malignancy, in the Philippines, it's more of infectious, then malignancy, and then collagen. This is the last one, and again, the most common findings is because of infection. As to the diagnostic approach in FUO, the first and the most important step is to do detailed and thorough history and meticulous physical examination. They found out that incomplete histories, ignored physical findings, and failure to correctly interpret data delayed accurate diagnosis. You must remember that you have to repeat clinical assessment on multiple occasions to reassess historical features or clinical findings that might have been missed previously. Some patients or parents may recall what was omitted, what was forgotten, or even found out to be trivial during the first history taking. FUO is also caused by common disorders, often with an unusual presentation. So it's more for common disorders with unusual presentations. Let's look at the age group. For children who are less than 6 years, they will have more of respiratory or genitourinary tract infection, localized infections like abscesses, osteomyelitis, and non-infectious causes. For the adolescents, tuberculosis is more likely and non-infectious causes, plus the other causes for your younger children. As to the history, you have to be exacting about the history. You look at the duration, the height, and the pattern of fever. How was the fever assessed? Did they use thermometers? Was the fever confirmed by someone other than the caregiver? Are there specific circumstances that precede temperature elevation? Was it taken after an exercise? Or maybe in the afternoon? Because in the afternoon, you usually have higher temperatures. Does the child appear ill or develop any signs or symptoms during the febrile episode? Whether or how quickly the fever responds to antipyretic drugs should also be elicited, because the lack of response to NSAIDs may indicate a non-infectious process. Is there associated sweating? Because if there's no associated sweating with fever, then it is highly likely that it is not infectious in nature. Look at the fever pattern. Generally, it is not useful except fever pattern observed in cases of malaria, because in malaria, you can either have fever every 2 or every 3 days. For intermittent fever, it is usually a return to normal at least once daily with high spikes and rapid effervescence. So when you have this intermittent fever, it might suggest pyogenic infections, tuberculosis, lymphoma, and juvenile idiopathic arthritis. For remittent fever, you will have fluctuating peaks and a baseline that does not return to normal. However, if you take in an antipyretic, then the remittent fever might be intermittent. This is seen most commonly in viral infections, but also in bacterial infections like endocarditis and other non-infectious causes. For sustained fever, persistent fever, it's usually persistent fever with little or no fluctuation. And they can occur in typhoid fever, typhus, and brucellosis. If you give antipyretics, then it might be remittent. As to relapsing fever, usually it's for patients who are febrile for 1 or more days between febrile episodes, and they can be seen with malaria, rat bite fever, and infection with Borrelia, and lymphoma. Also, what is important in the history is asking for exposures, contact with infected or otherwise ill persons, exposure to animals, which should include household pets, domestic animals in the community, and wild animals. As for travel history, also the place of residence, it should extend back to the time that they were born. It should also include the sites of travel, where there is it an endemic area for malaria? Did the patient take in prophylactic drugs when they went to that endemic area? Were they given vaccinations? Did they take in something, to take a contaminated food or water? Because if you take in contaminated food or water, you might have hepatitis or maybe typhoid fever. And then, of course, did they take in something from that area, artifacts, rocks, or soil? Okay? Did they bring it home? And were there any exposures to persons with recent history of travel? Aside from that, you also need to ask in for histories of consumption of game, meat, or raw shellfish, which can be clues to brucellosis, toxoplasmosis, tularemia, or hepatitis. History of pica, especially eating dirt, can be associated with visceral larva migrans and toxoplasmosis. How about exposure to medications? Prescription drugs. Beta-lactams are known to produce drug fever. Topical and non-prescription drugs, and nutritional supplements. Histories of surgical procedures, because if they have histories of abdominal surgery, they are increased risk of developing intra-abdominal abscesses. When you do your physical examination, you have to evaluate them when they are febrile. It is necessary to assess how ill the patient appears, and you can also determine the effect of sweating. If there's no sweating when they have fever, then you might rule in a non-infectious causes. Of course, you also look at the discrepancy between the heart rate and the temperature. You all know that when you have a 0.6 degree rise in temperature, at least you have 10 beats per minute increase in the heart rate. Look at the activity, the appearance, the vital signs, you check them. For history or weight loss, if there's weight loss, it's important, but it's not really very specific. Look at the growth parameters. If there is impairment of the linear growth or there's short stature, then you can rule in the possibility of a non-infectious cause. New physical findings can appear or change, and subtle abnormalities not originally appreciated can become apparent. Okay. In 25% of children admitted to the hospital with FUO, significant physical findings developed that were not present at the time of admission. For skin lesions, look at abnormalities and rashes. Petechiae, that can signify infectious endocarditis, bacteremia, viral and rickettsial infections, and for cat scratch disease, baby popular lesions can appear. Look at the eyes. You can see probably palpebral conjunctivitis, which may signify infectious mononucleosis or Newcastle disease, bulbar conjunctivitis for leptospirosis or Kawasaki disease, flectennular conjunctivitis for tuberculosis, and abnormal fundoscopic examination for biliary TB and non-infectious causes. Palpate for the sinuses. If there's tenderness, it might be that that patient might have sinusitis. Look at the mouth. Look for abscesses. Look for any facial infections. Pharyngeal hyperemia without exudate might mean that the patient has infectious mononucleosis, either caused by EBV or your CMV. Request for a chest x-ray. It might be consistent with pneumonia. You will see some infiltrates or maybe lymphadenopathies, especially for your TB. Cardiac murmur, especially for new onset, may suggest infective endocarditis. For patients who are more than 13 years of age, this is when you look at the discrepancy between the temperature and the heart rate. You expect heart rate to be high when you have fever, but if it's low, then it might mean that the patient can have any of this typhoid fever or maybe dengue, viral hemorrhagic fever, malaria, etc. For the abdomen, look at palpate for the liver and the spleen. If they have hepatosplenomegaly, then it's common in salmonellosis, brucellosis, cat scratch, infective endocarditis, and even malaria. If you palpate if there's tenderness on palpation on the liver edge, it might mean that this patient has liver abscesses or cat scratch disease. If you palpate for the bone and there's tenderness, then it might indicate osteomyelitis. And muscle tenderness can mean that there's trichinosis and arboviral infections. You can perform careful rectal, external genitalia, and pelvic examination. The presence of perirectal tenderness indicates pelvic abscess or tumor, and you need to also examine for the stool for maybe occult blood. When you do your laboratory evaluation, it will depend on the age of the patient, duration of the fever, and history and PE finding. It should be directed toward the most likely diagnostic possibilities and should be adjusted to the severity of the illness. Galit eh. In a critically ill child, rapid evaluation is important because if the child is not critically well, then you can do it slowly. Sometimes the diagnosis or the fever might even abate without the diagnosis. Now, these are the initial tests recommended for all patients with FUO, for all children with FUO. So this should be the initial test. For CBC and peripheral smear, look for anemia because this might be clues to malaria, infective endocarditis, tuberculosis, IBD, and SLE. For thrombocytosis, this can be a clue to Kawasaki disease. In children with more than 10,000 PMNs or 500 non-segmented neutrophils, it means that they might be at greater risk of serious bacterial infection. A typical lymphocytes generally indicates viral infection, and eosinophilia can be a clue to parasitic, fungal, and non-infectious causes. ESR and CRP have no significant diagnostic value, but they are general indicators of inflammation and can help in ruling out factitious fever. Yung factitious fever, yung may fever siya, pero walang okay lang, and then the ESR and the CRP are normal. Okay? Further evaluation and monitoring to the progress of the disease process can be used. Routine blood cultures, which should include aerobic and anaerobic cultures, should be obtained. And for infective endocarditis, several sets are warranted over 24 hours. So, paulitin mo siya. How about urinalysis and culture? In one series of FUO in children, failure to perform urinalysis and failure to investigate pyuria adequately were the most common laboratory errors. Radiographic study of the urinary tract, however, should be performed only when indicated. So chest X-ray is needed to evaluate for infiltrates and lymphadenopathy. You can also do diagnostic imaging for nasal sinuses, mastoids, and GI tract, but they should only be performed initially for specific indications. Tuberculin skin test. A negative tuberculin skin test result does not rule out TB. Ano yung mga instances na negative siya, pero meron? Kung malnourished yung bata, or kung sa state of anergy, yung kakaroon lang ng measles or any viral infections, you need to wait for a few weeks before you can do your testing. Stool cultures and examination for ova and parasites may be warranted in patients with loose stools or maybe those with recent travels. How about bone marrow examination? This is most useful in diagnosing non-infectious causes. It is less useful in determining infection. And to prove my point, there were 414 bone marrow examinations done for FUO in children. And of that 414, only one showed salmonella. You can do serologic examination, and this is targeted for targeted approach for to serologic studies. HIV serology for all children with FUO is warranted. Serologic testing for syphilis, especially for neonates, young infants, or adolescents with FUO. And of course, yung may history from the mothers who had STIs. You can do other serologic exam, but this is on a case-to-case basis. For extraintestinal amoebiasis, you can actually request for IFAT or songuloidiasis and other viral infections. And serum concentrations for IgA, IgG, and IgM, you need to request for those if the patients come in with recurrent or persistent fever and the initial evaluation is negative. If there's low concentration, then most likely they're because of immunodeficiency. You can also do imaging studies, children with persistent fever, elevated ESR and CRP, anorexia, weight loss, can rule out IBD. If you do abdominal imaging, you can also request for ultrasonography, CT scan, and MRI, and this can detect abscesses, tumors, and lymphadenopathy. Blood chemistries can also be requested, like hepatic enzymes, and serum chemistry, like PUN or creatinine, to evaluate renal and or hepatic involvement. If you have elevated hepatic enzymes, this might be clues to viral infection without distinctive features caused by EBV or either CMV. And you can do other blood chemistries. These are some of the other tests that you can request for, but of course on a case-to-case basis. In general, antibiotics and other medications should not be administered empirically as a diagnostic measure in children with FUO. Hindi po siya panggamit pagka-diagnose. But there are exceptions. One is non-steroidal agents in children with presumed juvenile idiopathic arthritis, formerly known as your JRA, and of course, anti-TB drugs in critically ill children thought to have disseminated tuberculosis. Please remember that empirical trials of broad-spectrum antibiotics generally do more to obscure than illuminate the etiology of FUO, and they can mask or delay establishing the diagnosis of infections, namely meningitis, parameningeal infection, endocarditis, or osteomyelitis. Now, this was modified from an algorithm for FUO in adults. So this is from the fundamentals of pediatrics, and this is an algorithm for FUO in children. So starting off with a diagnosis of FUO, which is more than 38 degrees centigrade for more than 3 weeks in the outpatient clinic, or more than 1 week in the hospital. So again, the first and the most important part is to do thorough PE and thorough history and physical examination. And then if you have positive findings for this one, you can do appropriate and specific diagnostic testing. However, if there's none, then you can do this baseline test. When you do this baseline test, and if you find any positive findings from this test, then you can do your appropriate and specific diagnostic testing. However, if still no positive findings from these laboratory examinations, then you can opt to do CT scan of the abdomen and pelvis with contrast. Then you can assign them to the most likely category. Now, the categories can be divided into infection, malignancy, autoimmune conditions, or your collagen vascular diseases, and the miscellaneous. But I'm more interested in your infectious one. So, after the baseline and still no diagnosis, then you can opt to request for this one, to the echo, sinus and mastoid x-rays. You can do lumbar punctures, liver profiles, the VDRL, HIV testing, ophthalmologic exam, yung mga slit lamp, ganun. Serologic test for CMV, EBV, ASO titer. And then if it can give you diagnosis for this one. If still no diagnosis, then you can do the transthoracic echocardiography or the transesophageal cardiography and some of this one. In summary, FUO remains a challenge. Some fevers remain of unknown origin, and they represent a source for humility on our part, but may at the same time serve as a stimulus for continued research. Please just keep in mind the diagnostic spectrum for FUO, the local epidemiology. In our country, you have more infectious causes, followed by malignancy, and then collagen vascular disease. So look at the big three. And please also remember that common infections present with unusual presentation rather than unusual presentation, or rather than unusual causes with common presentations. And then when potentially diagnostic clues are absent or misleading, return to basics. Repeat the history and the physical examination, and then you wait and see. When I was a resident, I have my own FUO, and I call this the GOK and the OGK. And GOK stands for God only knows, or only God knows. So, I also remember what Dr. Alikpala said when we were in training. And she said that when all else fails, when you think that this is not infectious in nature, don't be afraid to ask help. It doesn't make you less of a doctor when you refer. So with all else fails, you can refer to whoever you want to. So with that, I'd like to say thank you very much for listening.